So now, hello everyone. Welcome to our session on international workshops and webinars in medical education, hosted by Sadiq International Virtual University and Imamia Medics International. I'd like to invite Professor Lambert, who will be introducing and speaking to his topic on modern assessment in medical education. And before we begin, I'd like to introduce our moderator for today, Mr. Hasnan Zafar Baloch, who will be running the session. So please go ahead and welcome everybody.
Yeah, I think over to you, Prof. I think you can share your screen. And while Prof. Lambert will be sharing his slides, and I would just like to convey a message to all participants, like use chat to ask or share your feelings. There is a Q&A tab there at the bottom. So if you have any question, please do type in. At the end, we will have a Q&A session. So I will arrange all these questions and we will ask the Prof. Lambert. Over to you, Prof.
Thank you very much, Hasnan. Welcome to you all for this webinar. What I wanted to talk to you about today is an approach to assessment in medical education, which is, I wouldn't say quite new, but it's quite different to how we've used assessment traditionally. And if you, I've been around in medical education for almost 30 years, and if you are in medical education, for that long, you've seen many hypes, new things, and people jump on the bandwagon and people think, yes, this is new and we're all going to do it. But 5 or 10 years later, it's all gone again because it was just on vogue. So I feel it is my duty to talk, when I talk about programmatic assessment, and that's an assessment for learning. That's what I'm going to talk about tonight. I feel that it's important for me to explain where it comes from. How did we arrive at this point in development, and also a bit of what's the underlying evidence why this would be a better approach. And I'll start very broadly, and I'll gradually home in on programmatic assessment, and you will hopefully see where it comes from. So I will start with an overview, a very brief overview of what I mean by programmatic assessment, and I'll return to that later on in the presentation, so it will be quick. And then I start with the why, and the first one is just about changes that are happening around us in the world, and that actually force us to change medical education because we can't be left behind. And the second part is then focusing a bit more on medical education. How has medical education changed? What are the new insights, and how, why do we need to move forward in the development of medical education as well? And then I'll highlight some of the limitations of our traditional examination or our testing approach, and that we make some strange assumptions when we evaluate or assess our students purely with examinations or tests. And then I'll talk a bit more about programmatic assessment in depth, and I will end up with a summary. I expect to be talking for roughly half an hour. So programmatic assessment is basically a form of ongoing assessment using multiple instruments or multiple sources of information, which goes on continually. It's collated and collected in a dossier, a file, a portfolio, what have you. But the focus lies on meaningful triangulation, and I'll explain what I mean by meaningful triangulation, which allows us to make decisions which are proportional to the amount of information or the richness of information that we have. But it also requires us to look at the quality of the assessment in a different way than purely the traditional reliability, validity, and what have you. And that way we try to keep competence as an integrated and holistic phenomenon rather than trying to take it apart into little measurable units. So When you work in medical education and when you think about designing medical education, you have to think about future scenarios. Our first year students will be doctors in 6 years. They will be interns in 7 years. They will be trainees or residents. And then they hopefully will be consultants in 12, 13, 14 years from now. And so if we start educating now with the ways that we have been doing in the past 10 years, we'll be educating people for a future that might be vastly different to what it is, to the situation which is now. Somebody put it as we're trying to educate doctors for the 21st century with 20th century technology and 19th century educational methods. That's a bit bleak, but it shows that we really have to think about what is the future going to look like. 100 years ago, that might not have been a big problem because things were going slowly, but we're at a time where huge disruptions are taking place. And of course, the first and most obvious one, and the one that everybody is talking about, is artificial intelligence. There is the expectation that the role of the doctor will increasingly be substituted, augmented, supported by artificial intelligence. And for two reasons. First of all, because um, the two traditional things that a doctor did, making a diagnosis and deciding on therapeutic management, both will require or will be more supported. If we're being very fair, making a diagnosis is a data reduction activity. The patient tells you a whole story in history, you do your physical examination, there's a whole lot of information, and you try to summarize that in 1, 2, or 3 diagnoses. So a patient can tell you a whole story, you can do your physical examination, and you say pneumococcal pneumonia. That's basically data reduction. That's what AI is quite good at the moment. But when we're talking about initiating treatment, increasingly treatment is becoming patient bespoke, patient specific. Toxicogenomics, pharmacogenomics, all these things, genomic markers, they all require an ever more fine-tuned and tailored type of management. That is going to become so complex that it will require support by decision support systems or machine learned decision support systems. So that's an obvious one. The other one, which is interesting, is that there has been a change happening in how we see knowledge. Traditionally, knowledge was seen as something that the expert had and the non-expert did not have, and there was one truth. But increasingly, we're understanding that knowledge is actually something that we co-construct. There are different views on knowledge. There are different hues, different shades of gray, different perspectives on knowledge bit. And Wikipedia as a co-construction of knowledge platform is not the source or the origin of that change. To me, it's just a symptom of that we're seeing knowledge in a different way. The third one, which is interesting, and Rachel Botsman has written a nice book about it too, which is called Who Can You Trust? It is that we are looking at how we're managing trust in a different way. So in the old days, trust was based on knowing each other personally. In small communities, you couldn't violate the trust of another person because they knew you and everybody knew you. But then when communities became bigger, we developed institutions that manage trust. For example, if I want to buy a house and there is somebody selling a house, we go through a conveyancer. And the conveyancer manages the trust that if I don't pay, the seller doesn't have to sell. If the seller doesn't sell, I don't have to pay. But the conveyancer also manages transaction. What peer-to-peer networks, for example, do, or peer-to-peer economy or platforms do, is they manage the trust. So the taxi, when I step into a taxi, the taxi manages the trust. I don't get into a car with just anyone, but if it says taxi and it has a telephone number and a thing on top, I trust it. and it delivers the transaction, namely the ride from A to B. Uber is entirely different. Uber manages the trust in the platform, but the ride share, the product is basically something that happens between me and the Uber driver. So that's a fundamental change, and that peer-to-peer economy is taking off very quickly. Then one which I find a very interesting technological development, namely cognitive surplus. So a while ago, my wife said, oh, my electronic key of the car is no longer working and I think the battery needs changing. Can you change the battery? I had absolutely no idea how to change the battery. So what I did, I went online, typed in, how do you change a battery for this car? And someone had made a video, 25-second video, explaining exactly how to change the battery. That person doesn't know me. That person doesn't even know that I have a query, and yet that person is helping me. In the old days, I would have to know somebody who had the expertise, and they would be willing, either out of friendship or altruism or for a fee, to help me. Nowadays, people are helping each other, sharing their knowledge for free. That's an interesting thing because much of what we are delivering to our students, like lectures, is already in the cognitive surplus. If you type in development of the placenta, you will find at least 15 beautifully animated videos explaining exactly how to develop, how the placenta develops. If we're still focusing on we have to provide our students with lectures on the development of the placenta, we're not using that cognitive surplus. And then finally, open ledger systems, blockchain, so systems where we can actually record information by multiple users in such a way that it's always authenticated and it cannot be altered in an indecent way. And all those things are already leading to an expertise asymmetry between patient and doctor. Where in the old days, the doctor knew everything, the patient knew nothing. Now the patient comes in, and some patients come in and they've done some reading. And they may be wrong, or they may be right, but it alters the relationship between patient and doctor. The same happens between the learner and teacher. You probably have had experience where you were saying something and your students were quickly Googling it, using Google Scholar or what have you, and came back and said, oh, there's actually a new paper on this, and correct you. So that expertise asymmetry, the doctor knew everything, the patient knew nothing, or the teacher knew everything and the learner knew nothing, that is decreasing rapidly. And we'll have to adapt how we educate our students and for what we educate our students. So let's focus on medical education a bit. First of all, there is point of care information availability. I used to run around with my white coat and my concise Oxford Handbook of Surgery and concise Oxford Handbook of Medicine, and that was it. Nowadays, we have all the information at our fingertips. In many universities, the lecture is still the backbone of their educational system. And I'm not saying that the lecture is wrong, but we have to realize that the lecture was invented 500 years, 600 years ago, 800 years ago in some countries. And the word lecture derives from I have read. The Latin is from the Latin, and it meant I have read, because the student didn't have books. Individual letter printing techniques hadn't been invented yet. So the mode of learning and the mode of teaching was basically that the reader, the lecturer, read to the students, and that's how the students learned. So the lecturer had the affordance of the books and the students did not. And even when I studied a long time ago at a problem-based learning university, we had modern libraries, we had modern ways of accessing that information, but it was still based on a linear transaction of the universities controlled the learning. The universities controlled what was in our module books, what was in our lectures and practicals, and the university controlled the resources in the library. Nowadays, the students control their resources. The students, if they don't like your lecture, they will go online and find a better one. If they think that your learning management system does not really function, they'll build their Instagram or TikTok or Facebook group if they're a bit older, and they'll build their own learning management system. So there is a huge informal learning system happening with all the information that they want to access, whether it's correct information or incorrect information, whether it's relevant or irrelevant, is besides the point. The point is that we as universities no longer control the affordances or the resources for our students' learning. We look at a different type of safe and independent doctor. So in the old days, the safe and independent doctor was the somebody raised their hand. Okay. The safe and independent doctor was the doctor who knew everything, who had all the skills to treat the diseases that he or she would be faced with. And that's okay. At that time, so at that time, the idea of education was, and the same was for my education, is that when you graduate, you would be equipped with all the knowledge, skills, attitudes, and problem-solving ability that would last you for the rest of your career. Bar some updating, and of course, when new drugs came, you had to learn them, but that was basically it. Whereas now, we expect that students will have to continue to learn after graduation. Things are changing rapidly. The way the societal changes I was just highlighting, they're taking place. So we cannot predict what our students will have to be able to do, what they will have to be able to learn, what they will have to be able to know after graduation, and they probably will have to continue to learn. And that has a fundamental implication for the idea of a final examination. When I graduated, and my final examination or my final assessment decisions were based on the notion that I would have everything in my rucksack to last me for the rest of my career. And that warrants a final examination, a final check to see whether you're ready for the world. Nowadays, we expect that the graduation is actually just a transition to a new phase of learning. So that has implications for how we will have to teach, and it has implications for how we will have to educate. Because our span of control, that hasn't changed. Our span of control over the learner ends with graduation, and our responsibility to society starts with graduation. That hasn't changed. So if we're not preparing our students as lifelong learners, we're actually not serving our responsibility to society. One of the scenarios in medical education, one of the more popular scenarios in medical education, talking about the technological advances that guide learning, but also that guide clinical practice on the medical discipline, is that there will be more need for people with a humanistic approach to patient care. So if the diagnostic procedures, if the diagnostic decision making, if the decision on therapeutic management are going to be supported or augmented or even substituted by more technology, there will still be a need to have somebody who is there whom you can trust. And the doctor will therefore need to be more able to as a communicator, as a collaborator, and as a health advocate. These roles, one of our future scenarios is that these roles will become more important and more in demand by patients. So that will lead to an attention to more attention to the soft and complex skills. Then another point is medicine is not an easy job. And there is a lot about mental issues, resilience, toxic systems, etc. We need to be able to empower our learner. And even in the most problem-based and self-regulated and self-directed learning, active learning curricula, we allow the learner to take agency and control over their learning, but the assessment still remains very firmly under the control of the university or the faculty. That is, we think that's concerning, because after students graduate, we expect them to be able to self-assess, or to at least know where to find feedback about their strengths and weaknesses and how to improve. But if we never allow them to take that agency and control during their medical studies, how can they then suddenly magically transform upon graduation? So again, there is a need to rethink assessment into, at most universities, most medical schools, assessment is done to the students, whereas modern education requires that assessment is more and more done with the students. Wherever you are, in what discipline you are, there's probably some sort of competency framework. And competency frameworks, and I'll come back to them later on in this presentation, try to get competence as a holistic, as an integrated phenomenon, and try to avoid taking it apart in little measurable units. So instead of reductionist measurement, which we had in the past, we're trying to stay integrative. So the old model of medical competence, and that's when I started in medical education, was that medical competence could be defined as knowledge, skills, problem solving, and attitudes. And for each of these four aspects, there would be a perfect test. So if you had a good tests of knowledge, good tests of skills, good tests of problem solving, and good tests on attitude, and you combined all that, that was competent. But then the competency frameworks came. And the CANMATs and the GME and the GMCs are the most well-known ones, but there are multiple. And the important thing is that what we see as the traditional part of competence, medical expert or medical knowledge or good clinical care, is but one of these competencies. And all these soft or meta competencies actually are highlighted as very important. Communicator, collaborator, manager, health advocate, scholar, professional. They're all more than just making a diagnosis and instigating a treatment. Then finally, there's a need for more meaningful results and feedback. The evidence in the literature over the course of decades is abundant that when you provide your learner with meaningful feedback and you allow them to practice and to rehearse or to practice their weaknesses and improve their weaknesses and find ways to maintain their strength, and you observe again and you give feedback, what Erickson calls deliberate practice, it definitely leads to higher levels of expertise more quickly and with better retention. But unfortunately, at many medical schools, there is rarely direct observation and rarely direct feedback. That's something that we really would like to see change. So why programmatic assessment? Well, here are some assumptions in the old examinations. And when I say testing, I say testing as the typical multiple choice test or the OSCE or what have you, the old examination types. Well, the first one, and that's one that I haven't even mentioned here, is the first assumption is that you can express competence as a number. Have you ever told a patient that they're 43.7% healthy? You probably haven't. Why would we try to aim at telling a student that they're 43.7% competent? So we all agree that competence is so much more than one thing, and yet we still focus on numbers. But in order to arrive at that, and that whole development was mimicked on test psychology, and test psychology had to do some psychological testing was good for certain reasons. For example, it had to tell people apart. It had to tell whether you were normal or abnormal in terms of certain traits. It had to assume that you could measure a trait and express it as a number. But the question is whether that's transferable, and we've transferred that to medical assessment. The question is whether that is really transferable. So one assumption is that a trait can be seen, a trait like knowledge or skills or problem solving or attitudes can be seen as a stable and generic characteristic. So the idea was that you had a test for knowledge, a test for skills, for problem solving, and for attitudes. And of course, a test for knowledge should not test skills, and a test for skills should not test knowledge, and vice versa. And the whole idea was that there was one best test for each. I'll come back to that. So the assumption is that if I had a test, let's say here is a test with 4 items and 5 students, A, B, C, D, and E other students, then we hope the theoretical situation is that all the items would agree that student A is a good student, student B is slightly less good, and student E is the worst student. Actually, we would assume that if we were to give these 5 students a parallel test, a test which is equally difficult on the same topic but with slightly different questions, that again A would be the best student and E would be the worst performing student, and the rank ordering would be the same. Unfortunately, what we typically find is this scatter. If I were to express this as variance, as the whole variance in the data matrix, typically 70 to 75% is interaction, and only 20 to 25%, not even 20%, is what I really want to measure. So there's a lot of noise in our measurement. If our traits were so stable and generic as we believe them to be, we wouldn't find so much noise in the measurement. The fact that we're finding noise in the measurement doesn't mean that real life is just bad. It could also mean that the way we approach, the way we model competence scientifically is not a strong scientific modeling, not a strong scientific model. The second corollary of what we do in testing is that we have to treat individual items in themselves as meaningless. Allow me to explain what I mean. If I have a multiple choice test, on, let's say on internal medicine, and here's one item, and here's another item, and one student, let's say John, answers this item correctly and this item incorrectly, and another student, Jill, answers this item incorrectly but this item correctly, then John would get 0.5 on average and Jill would get 0.5 on average. I can live with that. But in an OSCE station, in a clinical skills examination, in a station-based examination, so John does well on a resuscitation station, but very poorly on a communication station, and therefore gets on average 50%. Jill does very poorly on a resuscitation station and very well on a communication station and also gets 50%. That stops making sense. Because, I mean, you cannot say to your patient, well, the resuscitation of your loved one went very poorly, but I can talk about it very well. It doesn't really make sense. So we're adding, in most tests, we're adding apples with oranges, and we get dodgy stats. Then the third one is that the only validity, the only part which is really valid, certainly if you take Cronbach's view, is that the sum scores determine what the test measure. So we add up these apples and oranges and it leads to a nice sum score, but what we're actually adding are things which should be recorded individually and should be evaluated individually. So you cannot say that the average between your resource performance and your communication performance is a meaningful average. So, and as a consequence of this thinking, traits as a stable and generic entity that can be measured and expressed in a single number. Of course, our psychometrics and our statistics are based on throwing away information, on elimination of information. Again, let me explain what I mean. So here are the answers, or here is a test and the possible answers of a student. At this point in time, I know exactly which errors the student made. I can explain and I give feedback to the student that motor neuron disease is not the most likely cause, but that adverse reaction to perindopril is the most likely cause. So there's a lot of feedback, there's a lot of information. But now I'm going to score this. And I've thrown away a lot of information. I don't know, I've lost the understanding of why this was incorrect. I simply know that item 1 was incorrect. Then I add them up and say, well, you got 1 correct out of 3, that's a score of 33%. Now I've lost the information of which items were answered correctly and which items were answered incorrectly. I only know, only thing that's left to me is how many items were answered correctly and how many items were answered incorrectly. And then finally, I compare it to some pass-fail score and I determine whether you're a pass or a fail. Now I've even lost the information, how many items were answered correctly and incorrectly. I've simply dichotomized it into a binary value. Was it enough or wasn't it enough? So the way we deal with tests is all based on throwing away information. I often say that the whole literature on standard setting is a whole literature on how to throw away information in the best possible way. Which of course led to the idea that there is one single best instrument for each trait. And if you look at the literature in the 1980s, 1970s, 1980s, and perhaps some early 1990s, many studies were there comparing item formats. Are open-ended questions better than multiple choice questions? Are practical exams better than written exams? Are computer-based better than written exams, etc.? It negates the fact that they all contribute, that every test has strengths, weaknesses, or you could say effects, side effects, or indications and contraindications. That is what you could argue. So seeing whether open-ended questions are better than multiple choice questions, or in the educational realm, is problem-based learning better than lecture-based learning, is basically a question like in medicine, it would be like asking whether NSAIDs, non-steroidal anti-inflammatory drugs are better than antibiotics. And the answer is depends on what you're trying to achieve. So in the mid-1990s, the realization came that actually every assessment modality had its strengths and weaknesses and had its specific purposes. So it's not about is A better than B? It is about how can I best use A in situation A and how can I best use B in situation B? And that's what finally led to the idea of programmatic assessment. So instead of focusing the whole development on trying to find the best instrument to measure problem solving, we went back and say, well, there are multiple instruments for everything. If we look at all these competencies, but we need to combine those. We need to build a program. I'm going to briefly take a detour here. If I were to translate this whole presentation into clinical practice, it would make a different type of sense. In the old and centuries ago, medicine had similar debates as was drug A, or everything could be solved with drug A. There has been a time when people, and I think that time is re-emerging, is where people try to treat patients by lab values only. That's what we do with testing. With numerical testing, we're actually treating our students with lab values only, with lab tests only. There has been a time where people believed in one method being the best. But increasingly in medicine, we come to understand that there are multiple drugs, multiple therapeutic options, and you have to tailor the therapeutic option to the specific patient. That's a similar development as currently going on in assessment, that the assessment has to be tailored to the individual students and that you need a program of assessment rather than one single test. It may be obvious that I'm not a big fan of national testing, because national testing is, again, one test that decides all, whereas we believe that it should be a program. Let me explain what I mean with these. Multiple instruments with meaningful triangulation. So if I look at workplace-based assessment or what we have, there is a whole plethora of instruments that we can use. So we can use direct observation, procedural skills, OSCEs, vivas, orals, short answer questions, multiple choice questions, whatever. And they all try to capture that vague and undefinable thing that we call medical competence. So if I put these instruments together in a traditional, let's say this would be a traditional assessment program, then you would get a score for your mini CX. You would get a score for your multiple choice examinations. You would get a score for your OSCEs, and so on and so forth. And each of these scores perhaps had to be satisfactory in order to pass. But we know that, for example, if I take OSCEs, clinical station-based examinations, if I take OSCE, we know that the correlation between one station, let's say your resuscitation station and your communication station, or your abdominal examination and your knee examination station, we know that the correlations between those stations are sometimes even negative, but they're barely higher than 0.1, 0.2. We also know that, let's say, if you were to compare the OSCE, the real OSCE, with a written test on clinical skills, correlations would be incredibly high. And the literature is almost unanimous. Correlations between tests elements, which have the same content but might be of a different format. Let's say you're asking similar things with an open-ended and a multiple choice questions. Correlations are extremely high. Correlations within an instrument between different contents. Let's say you've got a part on heart failure and a part on myocardial infarction in one multiple choice test. The correlations between those two things are extremely low. So things generalize very well if the content is the same, but if the format is different. Things correlate very poorly if the format is the same, but the content is different. So what I mean with meaningful triangulation is basically you take elements of all different tests, you combine them in a story, in a narrative, to tell you something about the competency domains. And you might think, yeah, that's nice, but that won't work. Well, as a clinician, you do it all the time. My standard example is a patient comes into your consulting room and complains about thirst and frequent urination and fatigue. Well, you examine the patient and you see poorly healing wounds. Then you palpate the peripheral arteries and you feel weak and absent peripheral arterial pulsations. you order a glucose, and you get a glucose level of 32 millimoles per liter. So now you've got verbal information, visual information, tactile information, and numerical information, but you can easily combine that to diabetes mellitus. So we, as humans, we're perfectly able to collate and triangulate information from various sources. We do it all the time as a clinician. We would never dream of saying to a patient, yeah, I'm afraid your glucose level is far too high, but fortunately your creatinine level is far too low. So on average, your lab tests are okay. But that's exactly what we're constantly saying in assessment. Your knee examination was incredibly poor, but fortunately your abdominal examination was very good. So on average, your skills are okay. That's what we do. What we want to do in programmatic assessment is actually force people, make your students with their staff members, with their teachers, take bits of information from the various assessment instruments and combine it and evaluate it. In order for that to work, it has to be continual and longitudinal. It can't be your simple final examination. It has to be an ongoing process, because how else could you give feedback? So the student analyzes, the teacher analyzes, they bring together all that information, and they do it on a continual basis. The same way you would do that with a more chronic patient. You see them regularly, you do your history, your physical examination, your pathology, what have you, your lab tests, you bring them together, and on a continual longitudinal process, you guide them on their way to being healthy again. So in programmatic assessment, not every assessment moment is a decision moment. This is your standard curriculum. You've got a module, there is a test. At the end of the test, there is a decision, pass, fail. If you fail, you either have to redo the test, or if you fail multiple times, you probably have to redo the module. If you pass the test, you go on to the next module and the next test, and the same procedure happens over and over again. So basically you end up with yes, no, or pass, fail, pass, fail, pass, fail. And then in the end, you have to reconstitute that multifaceted phenomenon of competence out of a couple of binary points. In programmatic assessment, there is a constant collection of information. That might be assessments, it might be feedback, it might be formal feedback, it might be self-assessment, self-analysis, what have you. And everything is collated in a dossier or in a portfolio, which allows you to be more proportional in your decision making. So if I got my portfolio and there's only a bit of information in it, I can't make high stakes decisions. So that's only useful for low stakes decisions. And if there's more information, the stakes become higher. And for high stakes decisions, really decisions whether you have to redo a year or whatever, or you actually fail to graduate, I need rich information, which is the same as a clinical procedure. A patient comes in, you know nothing about the patient, you're not going to make a very dramatic diagnosis. If you want to tell a patient that they've got a severe illness, you make sure that you've got enough diagnostic information. But if a patient comes in coughing and just tells you one or two things, you were very willing to say, oh, it's probably a common cold. So it's the same principle. The more high stakes the decision we make, the more information we need. Again, that's what big tests, national tests, or final examinations don't do. They're 1-point measurements with huge ramifications and huge possible implications. That's what programmatic, excuse me, that's what programmatic assessment tries to change. Here's a bit of a difficult part. So traditionally in testing, there are a couple of elements which are used to determine the quality of the assessment. And the two most well known are validity and reliability. So validity pertains to whether the test really measures what it purports to measure. The reason for it being that we cannot observe what we try to measure. Nobody has ever directly observed knowledge. You can observe somebody's height or waist circumference or what have you, but you can't observe somebody's knowledge or skills. You will have to observe them do or say something while they're doing or saying something in order to infer whether there is sufficient knowledge or sufficient problem solving or insight or what have you. That strength of that inference is how well we can infer from what we see, what we think is going on in the brains of our students. That is the realm of validity. Reliability. There are many ways of defining reliability, but typically in assessment, reliability is defined as test, retest reliability. I give a student a test, there's a score. Would that student get the same score if they were given a similar test? If I'm talking about narratives, if I'm talking about triangulation, if I'm talking about feedback, incorporating feedback, etc., I cannot just rely on that test, retest reliability. But there has to be a diversity of quality approaches. So here's the original idea. I have a test, I have a parallel test, and there are 3 levels of assumptions. If John scores 58% on the test, would he score again 58% on the parallel test? So would they get the same scores? The second one, if I have a group like my 5 students in the previous example from A to E, if A is the best performing and E is the most poorly performing, would the rank ordering be the same on the parallel test? That's basically, if you ever heard or used Kronberg's alpha, that is the underlying idea behind Kronberg's alpha. And the final one, and which is the simplest inference, is would the same students pass and fail? At least would I make the same decisions? There's another way of looking at that, which comes from qualitative research methodology, which is saturation. So I observe a student, I've got some observations, some information about a student, and I think the universe is yellow or orange. But I continue observing the students and I see different facets, different aspects of their competence. I see green, blue, red, and yellow. And I continue observing and I see again I see other aspects that I hadn't seen before. I see purple and black. And I go on, but there's nothing new. And I go on and there's again nothing new. I've reached saturation. I've seen all the aspects. There may be different aspects. So it's not reliability in terms of every test has to give the same number. I'm seeing different facets, different aspects of competence, and I keep generating, I keep collecting more information until I'm certain that more observation would not give me more information. Again, it's a diagnostic principle. You've made your diagnosis when you think that you have seen and heard and tested enough, and you're not going to continue with expensive testing when you've made your diagnosis. The other way of looking at it is that you can build quality and reliability into your organization. Your organization, the way you deal with assessment, can be trustworthy. For example, by making sure that if there are observation-based assessments in your program, that your staff is trained, that they know what they need to observe, that they know what they need to see, and that the students know how the assessment goes. There might be meetings, feedback on the learning goals with student and staff members. The student staff member, the coach or the mentor of whatever you may give a recommendation to you might want to change the fact that so if a student has a portfolio and a staff member reviews that portfolio with the student regularly, then the staff member has a dual role. On the one hand, it's that student's mentor, coach, guide, partner. On the other hand, it's also the person who's best positioned to make a decision as to whether the student's progress and performance is good enough or not, at par or not. So in a typical situation, the coach doesn't make that decision, but gives a recommendation. In a good situation, you ask the student to make a recommendation as well, and to actually give you information and to write something about, to give a background or a foundation for the recommendation. If the student and the coach agree, you can actually say, I'm going to give a marginal check. I'm going to check whether the student and the coach didn't do horse trading. If the students don't agree, you may say, okay, I want another coach, an independent person, to review the whole portfolio, to review the whole process, and to see who's right. Or there might actually still be insufficient agreement. You want another check. You want another coach to look at it. Or there might be a full committee looking at it. It's not about the details of this process. This process is just an illustration of that you can build reliability, trustworthiness, credibility into an organization. So instead of having just test, retest reliability, a numerical one, you can have a saturation of information. You can actually build trustworthiness in your organization. You can have checks and balances. And finally, that allows you, now you've got this ongoing assessment from various sources, triangulated in a meaningful way with feedback and a dialogue between the student and their mentor or their coach, with decision-making processes, determining whether it's good enough or not, or where the progress needs to improve and whether progress is good enough. Now I can keep that competence holistic as an integrated process, and I don't have to disentangle it into little measurable units, which allows me to give my students control. So in an ideal programmatic assessment / assessment for learning, initially it's the faculty that has control, but gradually you ask your students to take agency and control over their own assessment as well. Ideally, you would have a situation, but that's probably still a bridge too far. You would have a situation where final year medical students compile their portfolio, and instead of having a sort of final decision, they apply for graduation, like a job application. And they would say, well, here's what I have to show for myself. Here is what I've accumulated in trustworthy information about how I'm progressing. Which means that in that situation, there is an ongoing cycle. The portfolio contains all the information. The student writes a self-reflection or an analysis. I'd rather have a sort of analysis and certainly not a very wordy self-reflection. A meeting with a coach or a counselor or a mentor, whatever you want to call them. Learning goals, and a learning goal in programmatic assessment is not something like I'm going to try harder. Learning goals are manageable, doable things that will demonstrably lead to improvement. And the learning activity, and then the evaluation comes back in the portfolio. So it's an ongoing quality check, act, and improve cycle of the learner. Which, and I'm getting to my final slides, which means that we do not have these separate entities like knowledge, skills, attitude, problem solving, etc. And we don't think that they're each measurable in their own right. They are just different lenses, different ways of looking at competence, because competence is nebulous, it is vague, and it's difficult to really grasp and to find the boundaries. So we need different lenses to look and to make sense of it. And again, this seems odd. How do you work with that? Well, my clinical work was in chronic pain management. So many of my patients suffered from chronic benign low back pain. And I had my different lenses when I worked with those patients. There was no nociceptive component. There was a neurological component. There was an occupational component, a psychological component, an orthopedic sometimes, a pharmacotherapeutic, and a socioeconomic. And what I did with my patients was constantly looking at where do we tweak? Can we get most gain? So it was constantly using a different lens or a different magnifying glass and looking from a different perspective on that complex phenomenon of chronic benign low back pain. That's the same thing that we in programmatic assessment and assessment for learning try to do with our students. We don't try to pull competence apart into little measurable units. We keep it as a whole, but we constantly use different lenses to see where most progression can be made and where the student can become the best doctor they can be. So in summary, programmatic assessment is certainly not the solution to everything. There's a lot, the world is changing, and programmatic assessment is one piece of the whole puzzle. The world is changing, medical education is changing rapidly. The old approach to assessment, the testing and the examinations, no longer fits. It is like treating a patient on lab values only. So programmatic assessment is a way to continuously, in an integrative way and meaningfully assess our students and make assessment part of the learning process. So the focus is on feedback and assessment for learning. And it seems soft. You might think it's soft. It's actually quite a harsh way or a hard way of assessing because it's inescapable, because it's constantly aimed at improving the student and a self-regulated lifelong learner, somebody. So the most summative aspect in programmatic assessment is the student who fails to engage with the process, who fails to formulate doable learning goals, and who fails to enact on these learning goals and demonstrates improvement. That's a student who fails. So that's what I wanted to tell you in summary. Thank you very much. I'm happy to make my presentation available. Here is some of the background reading where it all comes from. Thank you very much.
Thank you, Prof. It was really very comprehensive. And we got some questions. The first question I would like to read is, do you agree with constructing one test containing few items which are psychometrically measured? It's each item with multiple instruments such as MCQ, OSCE, OSAT, and etc.
If I understand the question correctly, is whether, do I understand correctly whether I agree that there should be one test with one type of items that would capture it all? Is that the question?
But each item with multiple instruments.
Hassan, can you read the question again? Because I didn't get it clear as well.
Okay. May I ask Mariam if you could unmute and ask the question again? If you want me to repeat, do you agree with constructing one test containing few items which are psychometrically measured? It's each item with multiple instruments.
I think there are two aspects to that question. The first one is I agree that if you have one test, you can have multiple multiple item formats or multiple modalities in one test. There's absolutely no reason why you can't combine open-ended question and multiple choice question and an extended matching all in one test. There's absolutely no reason why you couldn't. The thing that I'm struggling with is one test. I'm just been advocating that you want a program, an ongoing program. So I would never use one test. I would use multiple assessments, moments, plus feedback in order to generate that rich information.
Yeah. How do you how you can do programmatic clinical assessment?
It's same. So the prerequisite for any form of clinical assessment is that the student is observed directly. So you cannot do good clinical assessment, whether it's programmatic or even in the old-fashioned way of thinking. You cannot do clinical assessment where the person who has to assess the student has to give a retrospective score and hasn't seen the patient, hasn't seen the student perform. So in programmatic assessment in the clinical workplace means that you have repeated observations with feedback, perhaps with a score, if you like scores, with scores, that you interlace it with tests which are perhaps more written or computer based, and that you bring it all together. But if you cannot, two things are important. The first one, there has to be direct observation. If you cannot directly observe your students, you cannot assess them. Secondly, if you focus on feedback, if you want to give your students feedback, make sure you follow up the feedback. My advice in most organizations when I'm asked to review an assessment system for at a medical school, for example, I often ask, do you give feedback? Yeah, we give feedback. Do you follow up? Oh, no, we don't have the time for it. My advice is always, then don't give feedback. If you don't give feedback, you don't follow up. To explain what I mean, I use the standard procedures that most journals have with manuscripts. So let's say I submit a manuscript to a journal and it comes back with reviewers' feedback and feedback of the handling editor, with an invitation to revise and resubmit. So what the journals nowadays require you to do is to make a table with all the feedback, detailing exactly how you have responded to the feedback, and provide a track changes version of your revised manuscript. That is assessment for learning. It means that you are given feedback, but it's checked whether you followed that feedback up. So in the clinical workplace, if you want to do programmatic assessment, you have to do that longitudinally. You have to have different sources of information. But the most important thing is the feedback has to be taken seriously, and the student has to demonstrate that they take on board the feedback.
Okay. The next question is student and coach agreeing, involving different coaches. How feasible it is with large number of students?
It's a matter of how much do you want to invest in quality of education. That's a simple answer. So if I'm being a bit cheeky, I would say that most universities do not really invest in education. Education is always too expensive, but they don't realize that education actually pays for research. If you look at a university as a business, education brings in money, research costs money. At my own university, the success rate in the last year with the major funding bodies was 14%. That means from every 7 proposals that had to be prepared, and you know how much work it is to develop a grant proposal, from every proposal, from the 7, only 1 got funded. So where was the time and the money? Where were the time and resources paid from the other 6? Well, certainly not from research funding, but from education. So that's the first thing. But it's not that easy because certainly now, when programmatic assessment is still, well, I wouldn't say entirely new, but it was first described in 2005. But where it's still taking off is you need good coaches. And not every university has sufficient staff members who have this aptitude for that coaching role, for that mentor or coaching role. So it's not just a matter of numbers and money. It is a matter of how many good coaches can you find. And a good coach can deal with 5 or 10 students, but that's it. You can't overload a coach with 20 students. That's too much. So how do you deal with large numbers? If you have sufficient staff members that can be trained to become good coaches, it's just a matter of how much do you want to invest. If you don't have it, it's a problem. So my former university, Maastricht University, is a university with an annual intake of 380 students. That's a relatively decent sized university then, a decent year cohort. They manage it. If I'm being cheeky again, but they want to invest in quality of education.
Right. Okay, thanks for the detailed answer. Other question asked, do programmatic assessment used for student progress or student mastery?
Both and. There are certain aspects in medicine that you can master. At some point in time, you have to master how to take a blood pressure. You have to master how to examine a knee. You have to master understanding a Frank Starling mechanism. But there are also parts in medicine that you will have to constantly improve. You hopefully will become a better communicator all the time. So you learn to do your communication in simple cases, but eventually you will have to learn to deal with very complex communication cases. Let's say you become a pediatrician and you've got a child and the parents, and you're trying to deal with the child and their illness, and the parents are fighting amongst each other in your consulting room. That's slightly more difficult than a straightforward, yes, you've got a common cold. So these are parts of competence that are never finished. They always become better, and they should always become better. But I wouldn't say that your taking a blood pressure always becomes better. At some point, it should be good enough, or a venipuncture should be good enough. Or knowing what you need to know about Frank Starling mechanism is good enough. So it's both and. It's not just for mastery, but you have to, the thing is when you work with the portfolio, at least you have to be very aware of which things can be ticked off as, okay, done that, know this, and which things require a constant improvement. The most important thing is that students become aware that they're never finished, that it's an ongoing learning. You keep on learning, and you take every situation in life, in your clinical practice, every situation as a learning situation. So we're not, traditional psychometrics compare students with each other. If all students had a perfect score on your test, you couldn't calculate Cronbach's alpha. It would be division by 0. So Cronbach's alpha, Kudo-Richardson, generalizability coefficients, they're all based on the assumption that there has to be a difference in performance between students. If all students are perfect, you can't calculate reliability in the traditional psychometric sense. Whereas if all my students were perfect on a relevant examination, I would be very happy as an educator. Programmatic assessment starts from another point of view, and it says, we are not interested in comparing John and Jill. We're only interested in assessing John to help John to become the best doctor he can be and to help Jill to become the best doctor she can be. So what can we assess to demonstrate that John today is optimally better than he was yesterday, and what can we advise John so that he will be optimally better tomorrow than he is today, and the same for Jill. Because our intake of medical students are students who are intelligent, motivated, who have already demonstrated for 20 years that they can learn and pass examinations. Of course they can. If we now tie up this whole assessment system to find the bad apples, where the prevalence of bad apples, certainly in the cognitive domain, the prevalence of bad apples is almost close to zero, we create a huge number needed to treat problem. That's just an NNT problem because our absolute risk reduction is zero. If we, on the other hand, focus our assessment system on taking these bright young people who are typically high achievers, if we could use our assessment system to stimulate them and to give them feedback, to drive them to become better every day, they become better. The Maastricht students, the Netherlands has this thing called progress test. 6 out of 8 medical schools jointly produce a test at graduate level, and all students of all year classes sit that test, and it's actually used to plot, and there's 4 tests per year, and it's used to sort of plot a growth curve of knowledge. It's also a beautiful comparison because per year there are 50,000 student results to compare. The students in that programmatic assessment outperform the rest of the Netherlands by a standard deviation. That's an effect size of 1 in messy field data. That's a huge effect. Students, in my experience as a learning coach at Maastricht University, what I've found, one of the biggest problems was students working too hard, students studying too much. We never had a problem of students doing too little. So I had my students who were studying 80 to 90 hours a week because it was so enticing, it was so motivated, and they wanted to do better. And my role was to turn them and bring them back to 40, 50 hours tops. I said, you shouldn't be doing more. That's too much. But it's all so enticing. It's all so interesting. So it is for 3 roles. It's for learning, it's for mastery, it is for improvement or ongoing competency development, and it's for improvement of learning how to learn. That was a very long answer.
Thanks, Prof. I think Prof. Shahid wants to ask a question. Prof. Shahid, can you please unmute yourself and ask directly the question?
Okay, thank you very much. First of all, Prof. Lambert, for a very informative talk, and the way you brought the assessment concepts that is going to be changed, the reliability, validity aspects in terms of Cronbach alpha and dimensionality of items within one test. But before I ask you a question, one very basic concepts for everyone. I would like to talk your impression on that. Then I ask my question. The thing is, why a student's performance on an item over test makes a test reliable, though it is the student's performance. But why it is the test becomes reliable or valid because of those? Because if the same assessment tool or the mix of an item and an assessment tool is administered to in a different cohort, we see a different reliability and validity. So why it ultimately goes to assessment being reliable or valid, whereas it is the students who are consistently performing well on an item makes it reliable or valid. This is my just your comment on that before I ask my actual question, which is the extreme side of the assessment that I'm looking forward to, is the reflection on improving own training program, how to improve assessment sort of practice for own progression in terms of agency that I have talked about and empowerment. When do you think a time will come that we are going to trust a candidate or a student or a trainee that when he says, I'm competent, and whatever way we sort of measure him, or in so many words to summarize, if we have a strong believer of the personalized learning, why are not we a strong believer of a personalized assessment?
Yeah, it's philosophically, I completely agree with you. Um, I so I'm a learner. I'm learning to play golf. So this morning I had a golf lesson again, like every week. So my golf teacher came and I was practicing and I was hitting my 7-iron and God, they were going well. I said, whoa, they're going well. I said, yeah, Braden, but I don't want to work on my 7-iron. I want to work on my drive. My drive is shocking. Oh, he said, let's come over here. And I showed him how shocking my drive was, how poor my technique was, etc. And said, oh yeah, I see what we're working on, what we're going to work on. How come I'm open and willing to share my weaknesses and my errors and almost make a fool out of myself? And it's only a game. And how come that we've got students who are studying for something that they're going to do for 40 years with huge ramifications, with and they're afraid to show their weaknesses? It's philosophically, I'm completely in your part of the course. It's it's amazing. We should have students who are willing to immediately show and challenge things and say, oh, I need more help on this. I need more help on that. But it's not happening. And I found that the culture around it and the financial situation around it are very important. Well, firstly, the Netherlands, for example, and I'm just comparing the Netherlands with Australia. The Netherlands has a publicly funded university system. So students do pay some tuition fee, but it's nothing. They pay 2,000 euros, whereas on average, a medical student costs 36,000 euros to be educated. So they pay a nominal fee. The rest is paid by the government. It's publicly funded. Australia doesn't have public funding anymore. Well, there is a so-called Higher Education Commonwealth support, but it's a loan. They have to pay it back. So a student, and in the US, it's even worse. So the student will have to incur a huge debt to study. As you can imagine, that a student in the Netherlands is much more willing to show a true reflection and true strengths and weaknesses and then get feedback on the weaknesses, even if it means that they have to study a year longer or some months longer. You can imagine that a student in Australia is not really willing to study a year longer because it's a huge debt. It incurs more. A student in the US, which makes it an entirely different view from the student or the stakes are entirely different. Students in Australia have to have a very competitive, what's called an ATAR system in high school, which is a sort of ranking system to demonstrate how well they did during high school. And if you want to get into medical school, you have to have an ATAR of 98, 99, the highest. And then they have to sit either a GAMSAT or a UMAT test, a situational judgment test, and an interview selection interview process. So highly competitive. Students in the Netherlands, if they have a certain tier of high school, they can get into university by lottery, medical school by lottery. That's a different point of view. So we've got this highly competitive students who had to be highly competitive to get into medical school, and then we tell them, and now you have to stop being competitive. It doesn't work. So I completely agree with your philosophy, and I think that's how it should be. But the culture, the financial situation, the financial support for students is entirely different in different countries. And I think we need to find ways of, so programmatic assessment is not a one-size-fits-all. If you start implementing it, you have to take into account is what type of students are coming in, what was their prior experience, what's their funding situation like, what's the stakes of them having to pass or fail a year, or having to be in med school a bit longer. That's an important point. Do you want me to comment to your comment about reliability as well?
Yeah, I would like you to comment. Reliability as a consequence of the tool, or as a consequence of the student's performance.
Yeah. Reliability is officially a characteristic of the tool, but it can only be estimated on the population of students. And that's why it's different with different groups of students, because they're all estimates. And the more students you have, if you have a very large cohort of students, your estimates are relatively stable. But if you've got small groups of students, then they may vary from small groups to small groups.
That's correct.
The other thing is that the more reliability is basically a measure of how well is your test able to tell students apart. That's basically what it is. How well can you tell students apart? And it's like having a yardstick. If your yardstick is in inches, and you've got students and you've got people, and you're measuring their height, and they're only millimeters apart, you will not find a difference, and your yardstick will be unreliable. If, on the other hand, you have a group of people who are very different, they're all each is 5 centimeters taller than the rest, your yardstick is reliable. So it's that interaction between how much difference is there between students and how accurate is your yardstick.
Okay. Hasnan, am I allowed to ask one more question if time? Hasnan?
Yes, Prof. Continue.
Okay. Prof. Lambert, I'm thoroughly enjoying your talk from all aspects, and particularly the critical review that you're giving on assessment. Regarding the programmatic assessment, there are two things that I can foresee. Currently, everybody is after standard. We all do by a standard set. So a standard setting method. Method being the cutoff point that we determine. We measure every student performance against that. But in programmatic assessment, it is not the standard setting method. More importantly, the standard setting strategy. How we put together all these assessment tools to make a narrative which by which we say that the students is fit to graduate or fit to pass. So basically, we need to understand in programmatic assessment the standard setting is strategy versus method. But when it comes to strategy, we often see that we compensate, say for example in written exam, the essay compensates the MCQ and all, but in clinical as well they compensate, short long cases can compensate with OSCE and all. But OSCE cannot compensate the written test, which makes it little more non-compensatory kind of thing. So the standard setting strategy in programmatic assessment is more important. Taken that, but would you consider that compensating one instrument for another instruments again will sort of jeopardize the assessment of a student's performance?
Yes, and I'm not a big fan of a compensatory model, and I think that if you compensate something, it should be. If you compensate information from various sources, it should be information that points in the same direction. It's like my example with the diabetes. That is compensatory because it points in the same direction. What we I would never have any model where I say, well, the OSCE compensates for the multiple choice, etc. I would never have that because it's apples and oranges and they don't compensate. Not even in the competency domains. I wouldn't say, oh, you're a poor communicator, but you're a good scholar. No, you have to show that you're also a good communicator. and that sounds odd when I talk in assessment. So I'm going to take it to the clinical realm.
Mhm.
You would never tell a patient that, let's say a patient with heart failure, you would never tell them that, okay, your autopnea is less, but your pretibial edema is more, so on average, yeah, that's okay. That compensates for each other. No, you would make sure that your pretibial edema is managed and your autopnea is managed and all the other things are managed. With every patient, you seek at how can I optimize these things. Then there is a point, there's a moment where you and the patient are going to decide that they're done with the treatment. They can be discharged. Uh, that is not a random number. It's not 43.7%, but that's a narrative agreement between you and the patient where you say, okay, this is, and I've had these discussions with chronic pain patients very often is, so this is the state at which we both can accept, or which we both think, yeah, that's optimal. That's the best we can manage. Or with acute pain patients where you say, okay, pain, we've managed the pain is gone, uh, uh, you can be discharged. It's a similar process in programmatic assessment. We don't make a cutoff score. We don't have a clear cut between competent and incompetent, but it's an
Correct.
ongoing story,
Over
which
time,
has to
over
be,
time.
yeah, which has to be defensible.
Yeah.
Yeah.
Okay. Thank you so much.
Okay, Prof, there's one question. What do you advise to increase the content reliability in Viva?
If you the, the, two things. First of all, have multiple cases. So if your Viva contains one case, it's never going to be reliable. You can structure until the cows come home. The structuring is not going to make it reliable. So have multiple cases in your Viva, multiple patient cases. The second one is have a new examiner for each case. Have an OSCE rotation. So if the same examiner examines the student on all cases, don't bother. There's called, there are all kinds of biases, primacy effect, saliency effects, halos. They're all going to implement, and you can actually see that the reliability, and Dave Swanson has done some work in that, and John Orsini has done some work in that. You will see that reliability doesn't go up. So you can test until the cows come home. Reliability will never be high. If you have a new examiner for each case, so the student goes for case one of the Viva to examiner A, and then for case two of the Viva to examiner B, and the other student starts with B and goes to A, etc. But so on, and so the examiner is nested within case, so it will dramatically improve reliability. The third lesson is 2 examiners per case doesn't add much. In terms of reliability, that's a waste of resources and a waste of time. So one new examiner for each case and multiple cases. That's the best way to improve reliability. Here's a new one. Here's something that has been recently detected. If you ask the examiner to score and you have a rubric which has more the educational or psychological jargon, such as highly competent, marginally competent, etc., you get less reliability than when you were to use what's called untrustable professional activity anchors, where, for example, where would you want to be? So given this Viva and given the performance on this Viva with this patient case, where would you want to be if your student were managing this type of patient? Do you want to be in the same room, ready to intervene? Will you be in the same ward? Will you be in the hospital? Will you be at home? Will you be at home asleep, for example? that seems to improve reliability even more. Interesting study. If you so there's one thing, yeah, if you want to read more about it, look up Swanson and look up John Orsini, and they've written about reliability or factors underlying the reliability of clinical examinations, and the same applies to vivas. And the other one has a funny title, Can I Leave the Theatre? It's written by Jennifer Weller and Brian Jolly and co-workers. And it's a very interesting study in the College of Anesthetists using entrustable professional activities. So in short, 3 things: make sure that you've got many different cases. Rather than one long, have a couple of more short ones. Nest your examiners within the cases. Don't use 2 examiners per case. And if possible, adapt your rubric to something, to more entrustable professional activity scale.
Okay, thanks for your detailed answer. There's another question which I need your advice. How we could manage the time to perform all these different methods of evaluation?
Yep. There's one thing that you can't go around, is that if you want to have quality assessment, you need to invest. If I want to buy a Mercedes, I need to dish out more money than if I want to buy a simple Fiat. So again, it's a matter of how much is the organization willing to invest. The second thing, however, is you know how real estate agents always say the 3 most important issues for a property is location, location, location. Here it's expertise, expertise, expertise. Actually, it's quite funny that at least in Australia and in the Netherlands, if you want to teach kindergarten children, primary school children, or high school children, you need a pedagogical training or an educational training. If you want to teach future doctors, you don't need pedagogical training. It's actually quite funny. The thing with any type of observation-based assessment, and an OSCE is also an observation-based assessment, requires expertise. It's basically a process of diagnosing, but you're not diagnosing disease, you're diagnosing discompetence. And as you know, the way you're able to probably see 40 patients a day and diagnose 40 patients a day, because you all have the expertise in your fields to diagnose, to make those quick diagnoses based on extensive expertise and their experience. If you had the same extensive expertise and experiences in diagnosing discompetence, then it would not be a very onerous task. The problem is that, and again, literature is gradually moving into that, is that when you diagnose disease, you have a whole jargon. You can actually talk about, you talk about your patient having heart failure, congestive heart failure with, etc. And the whole symptomatology, there's a whole jargon, there's a whole language that you can use to describe disease. But if it comes down to describing discompetence, we have no jargon. Yeah, we flee into numbers, but we don't have a jargon. And the medical education and assessment literature is gradually developing that jargon. So there are studies that look at what do people actually mean if they say that the student is not competent, or is not there yet, or doesn't have it, doesn't get it. What does that mean? What are they looking for? So if we were able to ensure that all our staff were properly trained in that type of assessment, it would take half the time. As in your disciplines, making a diagnosis takes half the time because of your expertise compared to somebody with far less expertise. So reading, I was a portfolio mentor, portfolio coach in Maastricht. reading a full portfolio, the first portfolio took me half an hour, 3/4 of an hour to read. After a year or two, it took me 10 minutes because I knew what I was looking for. So staff development, it is a form of investment, but it's also a form, the efficiency comes from staff development.
Prof. Lambert, one comment. I'm really moved with your saying that in a medical profession, we are taken into the institution as an based on our expertise in our respective discipline, but not an expert in teaching, learning, or pedagogical training. That makes me really, I'm impressed with this comment. We hardly see that when we interview people taking into, say, a teaching, learning system. We never look at their pedagogical training, being a trained person in teaching, learning, or assessment. From that perspective, what is your comment that observed score that a student actually score may not be the true score that reflects his performance? It may be the standard error of the measurements in terms of written tests or standard error of estimate in terms of OSCE. And we never look at that. We look at the reliability in terms of alpha and other. What we never look when we do the evaluation of assessment, I hardly see in many institutions that I have been working with, nobody really talked about the standard error of measurement, which really reflects how much reliable our instrument is. What is your comment on that?
Yeah, you're spot on. I know of an organization that does a form of national testing, and I've seen the publicly the published results. It was one of the colleges somewhere in the world who had a failure rate of 50%, a nice normal distribution. The cutoff score was around 50%, and the reliability was 0.75. So I did indeed, just for fun, well, then you can calculate the standard error of measurement, and the standard error of measurement, if your reliability is 0.75, that means that your standard error of measurement is half a standard deviation. You can do the math is simple, which means that the 95% confidence interval is roughly equal. Well, it's 1.96 standard error of measurement, but let's say it's 2 standard error of measurement. So it's roughly equal to plus or minus a standard deviation around the mean. That's 68% of the area under the curve, which means that there are 68% of the students or those candidates for whom I cannot say with the famous p less or equal to 0.05 that they passed or failed. It's only the top 16% where I've got a p of less or equal to 0.05 that they are pass, and the bottom 16% where I've got a p less or equal to 0.05 that they are failed. The rest, I wouldn't prescribe aspirin on those data, but we're willing to make people thousands of dollars or pounds or euros pay extra based on those feeble data. And I think that we should stop reporting Chromebox alpha. We should start reporting standard errors of measurement, calculate the 95% interval around the cutoff score, and actually tell the area under the curve and tell about how many students can't we be certain whether they're true pass or true fails. There are far too many false positives and false negatives in our system. I think you're spot on.
Okay, I think I will take another last question. If anybody would like to ask question, just raise hand. One last question. I mean, I very hard to stop, but we have to actually. We already exceeded the time, you know. Anyone who would like to ask question? No, it's okay. I mean, participants are enjoying, and there are a lot of back channel feedback. They really enjoyed the way you honestly did a postmortem on assessment. So I mean, I personally learn a lot. So if there's no question, can I ask Prof. Shabi Zaidi to say the final words? Prof. Shabi Zaidi, can you please unmute yourself?
Sure. Thank you so much, Professor. It was a wonderful talk. It was more than a talk. It was an interaction, a dialogue, an exchange of masterly. I mean, some of the terminologies were totally alien to me. I thoroughly enjoyed
Sorry.
between you and Shahid and all the other speakers and comments. It was a masterly presentation. I'm grateful to you, sir, for giving time to Sadiq International University. Such an invaluable presentation. It will be uploaded on our webpage for all the others who missed this opportunity to listen to you. May I also request you to come back whenever you have time in the new year. I'd be very grateful on behalf of Sadiq International University. Thank you, and stay safe and stay blessed, sir.
Thank you for your kind words, and I hope you all stay safe and healthy.
Thank you so much, Prof. Lambert. Thank you, indeed.
May I invite Ms. Shifa to announce the next activity from this platform?
Thank you so much, Dr. Schuerth, and everybody that was here today to join us in this very special event. I just wanted to announce our next event, this time next week, 11 o'clock GMT, October 17th. We have our very own Professor Shahid Hassan from Malaysia, who will be joining us to speak to a workshop on psychometrics of measurements, instruments in assessment to ensure continuing quality improvement.
Beautiful.
So again, I didn't implore you all to come and join us and see you next week.
Thank you, everybody. Thank you, Asnan. Thank you, Professor Lambert. We'll see you again, hopefully. Thank you, all the participants. Goodbye. We'll see you again.
Goodbye.
Goodbye. Goodbye.